Okay, I'm happy to introduce Dr. J today. Through just a cold call, he became acquainted with a small group of us that meet weekly. It's not associated with this necessarily with this group, but we meet once a week just to have lunch and tell bad stories. And through this group, he went on a path of learning about prostate cancer. And I want to make sure that you understand, he is not a specialist in any way in prostate cancer. He's a psychiatrist, which probably I could make use of. But we've come to know him well. He just published a new book that George has already mentioned. It's an easy read, and it's well done on the path he took to find out what was the best thing for him to do. So Dr. J, come on down. We're happy to have you with us, and you're buying the next lunch.
I thought the lunch meetings were for group therapy. You guys have gotten a lot better.
You got to turn yourself on. Where it says on. Say something, see if it's working right.
Good morning.
Good morning. Start bullshitting till I get your thing up here.
This is the first meeting I've been to. I work on Saturdays, so I fortunately got acquainted with the fellows at Thursday afternoon lunch at a Chinese restaurant in La Mesa. And I have to say that if you had told me 2 years ago I'd be speaking here, my first response would have been, gosh, I guess that means I developed prostate cancer, because this is not an area I was ever particularly interested in my own work.
All you do is roll this wheel.
Okay, cool.
Okay?
Now, my background was originally in general medicine, and then I started doing pain research at UCLA back in '73, when we were the first to investigate in a clinical study acupuncture that we just learned about when Nixon went to China. And for the first time in my medical career, I actually had a lot of time, and I could interview our subjects as long as I wanted. And some of them had had decades-long pain syndromes, which is why they came to us. And some of them had traveled to the Far East and the Near East and South America, and they were intelligent, they were seekers, and some of the interviews went on for like 2 hours because I was enjoying it so much, not that they really needed a 2-hour interview. And from there, I got for the first time the idea of doing psychiatry, where I could have the same kind of interactions with my patients. Last thing I ever thought I was going to be as a psychiatrist. But although I've spent half my time in psychiatry, the other half has been to investigate a problem that I learned about my first year in medical school back in '67. And it was why people respond so differently to the same medication at the same dosage. And as you see in everyday life, why people respond so differently to alcohol or caffeine. And yet, what we do is usually in medicine prescribe all our drugs, one size fits all. No matter your age, your size, your state of health. And the other was that the third leading cause of death in America, year after year, decade after decade, is medication reactions. 150,000 people a year. And this is at the dosages that the drug companies and the FDA are telling us to prescribe. So I started wondering about that, and I've been doing research on that issue for a very long time. I published a couple books on that topic. The most well-known one, not very well-known, I will say, was this one that came out. It was about drug industry, it was about FDA, it was about what people can do to protect themselves from that kind of problem. And it has to do with individualizing dosaging to people and getting histories Have you had problems with medications? Are you prone to side effects? Are you sensitive to alcohol? And if you get that kind of picture, you always start people at low doses. For example, in my practice, when I prescribe Prozac, an antidepressant that everybody's heard of, the recommended dose is 20 milligrams to start. I start people at 5. If they give me a history of sensitivity and reactivity, I start them at 5 or 2.5. And they often do well at lower doses. Half my patients never even need the doses that are recommended that I should use. There was a study that came out before Prozac was approved showing that 50% of people only needed 5 milligrams, yet they approved 20 milligrams as a starting dose for everybody. So it explains why side effects have been a real problem, and sometimes very serious ones, with these drugs. In any event, when I was diagnosed with prostate cancer back in December 2011, I was not thinking about writing a book on this topic. It's only because I learned so much that I thought was so important to send a message out to people that I decided to do it. Now I'm sorry, I should go a little bit backwards here. Another corollary of my issue of medications and dosaging is if you can treat people with certain conditions with natural remedies, why not? So I've published these books, and it turns out there are actually a lot of natural remedies that work for these conditions for a large number of people, and they aren't stressed in everyday medical practice. So this is the book I published. We just posted it up at Amazon a couple months ago. I self-published it because it's 3 times faster to do it that way. And it's been a lot of fun and a real learning experience. Now, when Jean came into my life after I made a call and called me back, I was on the road to being one of these 40,000 people. This is from Dr. Scholl's, Invasions of the Prostate Snatchers, who is currently my doctor. After getting other consultations, I ultimately went to him. These are the statistics many of you know well. 240,000 men will be diagnosed with this year. 30,000 men will die here in the US and 280,000 worldwide. As said previously, 1 in 6 of us will ultimately develop prostate cancer. Prostate cancer is the second leading cause of cancer death in America. And it's interesting, many of the statistics are very similar to those regarding women with breast cancer. And they're both hormonally related conditions, so it's very interesting. So, when I was at Kaiser, which is where I was when I was diagnosed, my PSAs were high, 15.3, 13.4. And of course, that was very worrisome. At the same time, I've had a very gyrating experience with PSA levels. Back in '66, 7.1. And my urologist, who I don't think I quite appreciate how good he was, although I did like him and we got along very well, he kept saying to me, I don't want to biopsy you. Now you know how many urologists would biopsy a PSA at 7.1, probably about 95%. They'd be drooling for the mouth to do it. But he said, I don't think this is cancer. He said, I think this is from the prostate infections you've had previously and a large prostate, and he held off. And it gyrated up and down, and there were more of these done, usually every year. And then finally in 2009, it went up to 8.4, the highest ever, which did scare me. But we repeated it, 2 weeks later, and it was 4.5. So I just thought, typical gyration. But then in November 2011, it was consistently high. So we went to biopsy. Now, I had never heard of a targeted biopsy where they use MRI or color Doppler ultrasound, which I'll talk about in a little while. This is just your usual random blind biopsy. And he did get 4 cores that were positive for cancer out of 14, which is a goodly number. So I'd like to quote George here as to what PSA is, because people ask me, well, what is PSA? Because there's so much talk and controversy about it now. And I'm always emphatic about the need to continue PSA testing every year from man when he's 50 to old age. It's like an engine light going off. It doesn't always mean prostate cancer, and it's important for men to know that. It can be high for other reasons, none of which my urologist at Kaiser in 2011 told me about. It can be an enlarged prostate. My prostate was 75 cc's, normal is 40. That adds points to your PSA level. Previous or current prostate infections. If you've had orgasm within the past day or two, the previous day or two before your PSA level, that pushes out more PSA, prostate-specific antigen, into the bloodstream. That can elevate it. Or bicycle riding or exercise bike, which puts pressure on the perineal area, and it supposedly can squeeze out some extra PSA. So men should always be told about that, and it should be repeated with them avoiding any of these that could artificially elevate it. PSA is 75% accurate, and although I heard that, and I wasn't sure my PSA levels were accurate, I still was scared as heck, because they might be. So I went online to what's called the prostatecalculator.org, and it gives you these statistics, and I went there, and it said that with my PSA level and my 4 biopsy cores, it is likely that my prostate cancer had already spread beyond the prostate. That affected a couple nights' sleep, to say the least. Oh, wrong way again. So I had the biopsy, 4 were positive. Fortunately, it was Gleason 6, which is the lowest grade of aggressiveness. In fact, I watched this DVD, as I often do, from the last meeting where Dr. Lamb said they're not even sure they should be calling it cancer at this point, which was nice to hear. Dr. Scholl's in his book says pretty much the same thing, but nevertheless, it's called cancer on the pathology report. And my doctor said, well, with this, you've got these 4 cores, and you've got this high PSA. You're not even low risk, you're intermediate risk. And your choices are prostatectomy, prostate removal surgery, or radiation. That's it. Above 10 PSA, 3 or more cores with prostate cancer, that's the road. That's where you go, and that's what many men hear. So I signed up for surgery. You know, what were the choices? And you know, I thought about what was called then watchful waiting, but I thought with this kind of dynamite in my prostate, I didn't want to just wait. I thought there was too much risk in the prostate calculator, stating it may have already been spread. I thought I better get to it, and I was on the surgery schedule. So I met with a nurse at Kaiser, a very nice lady. She tells you, gives you a lot of good information, and also told me about the Kaiser support group, but it was December, and they weren't meeting in December. And she also told me about this group. And she didn't know if they were meeting in December or not, so I placed the call. And Jean called me back, and forever changed my life, as I will show. Okay, so as I thought about all this, and as I met for the first time with the men, Jean, George, some other fellows who were here today, Chuck, Robert, Larry, we started talking, and they said, well, you know, they mentioned this prostate MRI. And I'm sitting there thinking, by gosh, is there any other area of the body where you wouldn't get an MRI before you did surgery? I mean, that's insane. I mean, they don't even know what I have and where it is. Really. The surgeons are all saying to me, well, if you have it in one place, which we knew I did, it's everywhere. And that's pretty scary. So, and I also heard about this color Doppler ultrasound, which is a computerized form of ultrasound, very different than the ultrasound they use to measure your prostate size by the regular urologist, that can also see into the prostate and see the cancer. Now this MRI is revolutionary. One of the reasons I wrote the book is no one seems to know about it. Few doctors tell their patients about it. Few doctors know what it is. It's only available in a few places, and yet it's a game changer. Because I had the MRI done, I got the smaller size at 1.5 Tesla done at Sharp Hospital here, and it showed that one cancer we knew about on the left side, and that was it. And it was small, medium-sized, not horrifically large. And best of all, it was located in a kind of safe, neutral zone of the prostate gland, not near any vital structures. Didn't seem to be spreading. There wasn't any cancer anywhere else. So this MRI will be a game changer because it will finally allow us to tell you what you have and where you have it. And it will lead to, I think, over the next decade, as some of these changes start really getting used by the broader medical community, it will allow us to go from blind biopsies or random biopsies to targeted biopsies, where the doctors can actually aim for the areas of concern, which will make the biopsies more accurate, and it'll also require fewer biopsy pieces, which reduces the risk of infection. We have 1.5 million men are biopsied a year. Well, 1.5 biopsies are done a year, and it's estimated by the experts we trust to be 50% too many. So if a man, if a man has a high PSA, we do an MRI first and see, is there something to biopsy? And if there isn't, we wait and watch. Repeat it. Or we repeat the color Doppler, as some doctors can do in their offices, which is even easier. And if we're more accurate with our biopsies, we won't have to repeat them so often. You know, right now with the blind biopsy, where they don't get a piece of cancer, they worry, well, maybe we just missed it. So we should do it again and again. To be sure, some doctors do what are called saturation biopsies, where they'll put a man under anesthesia and take 30 or 40 pieces. Hopefully that will become something of the past. And more accurate biopsies will give us, more accurate diagnoses will give us the choice of more sophisticated treatments. So is this new prostate biopsy, prostate MRI ready for prime time? And that's the big question. I don't think most urologists think it is. And the reason things happen so slowly in medicine, and the reason it's going to take another 5 to 8 years for all this to get going for real, is that first there have to be studies that show it is accurate. Then there have to be replication studies by different groups and funding obtained to do new studies that take years to do, to be confirming the original studies. And then the urology associations and medical associations have to look at the data and give their stamp of approval, and that's a very long process. But when I began learning all these things, I got every book I could find and read every book I could find. And I love this quote, which is Peter Scardino, probably the best known, certainly one of the most respected urologists in America at Sloan Kettering. I've heard that he's done like 1,500 prostatectomies and has great results. But if I don't see anything on MRI, it helps reassure me you probably don't have a large life-threatening cancer. I don't rely just on the digital rectal exam, the PSA, the biopsy results, or the MRI alone. But if you put it all together, we can get a pretty good idea of what's going on. And that MRI was the key piece in addition to all the others for me. And then when you look at the places that are doing it, you say to yourself, well, there must be something useful about this. MD Anderson, Duke, Jefferson in Philadelphia, Mass General, Mayo Clinic, UCLA, UCSF. These are pretty top-notch places. So the thing I heard from 4 different urologists urologic surgeons was if you have it in one place, you have it all over. And I think that's the general belief, which is why things are driven toward the really aggressive therapies, prostate cancer, prostatectomy, and radiation. And the people I spoke to were, really good people. So, and that was another reason I was on the surgery schedule. I figured, well, then I have to get it out. But as I was doing my research and looking at all these things, I found a study by the Cleveland Clinic, published in 2012. Interesting study, really another, I think, game-changing study. They took 431 men who were found to have unilateral prostate cancer on biopsy on one side. So of those, 179 chose to have a radical prostatectomy. So of those 79, the pathologic analysis showed that 50% still only had it on one side. 50 people, that's 28%. The other 129 had it on both sides. Well, I guess the doctors were right. Most men have it on both sides. But of those 129 who had it on both sides, the cancer on the other side was insignificant, small, little, non-threatening cancers in 77 of those 129, and only 52 had significant cancer elsewhere. So in other words, of that total of 179 men who had the prostatectomy, 71% did not have significant bilateral disease. So all those men, those 129 men, 27 men, did not need radical prostatectomy. Only 29% did. So another aspect of the new multiparametric and directal MRI are new focal therapies. The better diagnostics will lead to better, more specific treatments. Not everybody will be wanting or needing a radical prostatectomy or radiation that also hits the entire prostate area. Mentioned earlier, some people here have had the cryotherapy, which is a freezing technique that is done by a probe. This has been tried as a full prostate removal treatment, but I think its future really is in the focal therapy. If you have a lesion like I have and you want to get it out, this will be one of the treatment choices. The same thing with HIFU, high intensity focused ultrasound. That also will be more and more aimed at the focal lesions. And then there's another one coming on board. It's actually being done as part of clinical trials, but it's available and anybody can sign up for it, called focused laser ablation, or FLA, which again, the probe will, and using MRI, these will all now be using MRI to really be sure that they're getting to the right spot. And this laser is done that way too, with MRI. And it will put a probe right into the cancer, and it will burn it with laser heat. And they watch, they can actually see on MRI the change in the tissue, not just in the cancer lesion, but around it. They'll do an extra ring around it to make sure they got it all. And this can all be seen as they're doing it via the MRI. And this will become the equivalent of a lumpectomy in a woman. This will be a lumpectomy in a man with prostate cancer. And of course, these therapies, because they're more specific and they're not just affecting the entire area, will cause less problems as far as the real worrisome sexual dysfunctions, bladder control problems, and even the rectal injury and burn that can occur with radiation. So, as I said, when I read about was told about watchful waiting, which meant fairly much doing nothing except watching the PSAs, hopefully not going up, but they might. I turned that down. I thought the surgery was more likely to give me long-term better results. But active surveillance is different now. Again, the MRIs, and for the doctors who use the color Doppler, these are game changers because you're not just passively waiting for your fate to be delivered to you. You now can really watch what's going on. You can follow the PSAs. You can do the digital rectal exams, but hopefully that won't be an issue, really. I mean, you will do them, but hopefully that won't be how you're notified it's gotten worse, because you can see it now. I had a, well, let me show you. Let's see where this is exactly. Get back to that. The story for me, after I decided to pursue active surveillance, took another turn. I guess this is just the way it is with this darn disease. My PSA down the bottom in February 2012 was 14.4, and then in May it was the same, and then in August there it's 13. And I'm doing fine. I'm feeling pretty safe. I have already seen Dr. Scholes. He did a color Doppler on me, and it showed the same thing that the MRI showed. And I'm feeling pretty secure. And then in late October, it doubles, 26.6. So I'm reaching for the Sominex for the next week or two, which I don't recommend as a drug, actually, but. So I repeated again a week later, and it still was up there. So I'm freaking out, and I called I emailed Dr. Scholes, who's great because he responds to emails. And he said, well, you know, I don't think that's cancer. That's just unusual that it would do something like that. Now, I had made a couple changes in diet for other reasons. You know, you don't know what may have had to do with this. So I was having some hypoglycemia, and I tend to be a vegetarian, so I added chicken to my diet, a lot of chicken. And I was buying store-bought chicken, which is said to have all kinds of stuff in it. So I didn't know. So I stopped eating the chicken, and my numbers went down again. I was also fiddling with a few different supplements, so I don't really know. He said to me, well, you know, you probably have an infection. Why don't you just take Cipro for 3 weeks? Now, I'm the person in the world you don't say something like that to, because I published a paper back in 2001 about the horrific side effects that can occur. They don't usually occur, but that can occur with the drugs Cipro and Levaquin and Avalox, which are known as the fluoroquinolone antibiotics. They're very powerful. They can be extremely effective or life-saving, but they're often used when they don't need to be used for bladder infection and sinus infections, and they really should not, because they can have devastating, permanent, or very long-lasting side effects. So I declined that offer, turned it down, and I just got my diet back where it was, and it came back down, and it's stayed that way now for, I guess, about 8 months. But like someone said earlier, one of the speakers said, we're always on active surveillance. Once you're diagnosed, you're always on active surveillance. So let's see, where was I? Well, that's not the right way. In the book, I tried to add a few things that I didn't know a lot about, but I wanted to let people know what might be developing. I think this is going to be the Renaissance decade for prostate cancer diagnosis and treatment. I think that the way we will be addressing this, even mainstream doctors will be addressing this 10 years from now, will be very different than how they are continued to address it today. And I hope so, because technology is really finally going to help us turn a big corner. The MRI guided biopsy and the ultrasound MRI fusion methodology will just make biopsies a whole different approach. And treatment too, as I mentioned, with the focal therapies. I've had some nice interactions by email with Dr. Almeida about his C11 acetate PET CT scan for diagnosing metastases, metastatic disease, which is so key for men who have more aggressive cancers in terms of their treatment decisions. The choline one is done at Mayo Clinic. And I asked Dr. Almeida, I said, well, if this is so effective at identifying metastatic disease, shouldn't it have a role in men who are in their initial phase of diagnosis, if they're diagnosed with an aggressive cancer and there's some question of whether it's still within the prostate versus has spread outside the prostate, because that's such a key factor in deciding on treatment. And he said, actually, they're beginning to do that. So I want you all to know that he is open to newly diagnosed men who are wondering if there may be spread beyond the prostate. He is looking at that and doing his scan on men with that.
Can I interrupt just
Yeah.
to say that I'm hoping to get Dr. Almeida to come back and talk to us later this year about that very subject. I'm sorry.
Sure. One of the newer things on the horizon, actually was just recently approved, is Alpharadin. And this is a fascinating substance that is attracted to bone metastases in prostate cancer and I believe also in breast cancer, and can go and actually destroy the metastatic disease in bone. The studies show increased survival by 3 to 5 or 6 months. But you have to remember that many of the people in those studies had very advanced disease. People who were caught earlier, and the whole thing with prostate cancer is catch it all as early as possible, I would think would have a much better expectancy than those numbers. New medications, I always write about what I know, and I haven't had to do that yet, so I don't write much about that. I don't have experience with it personally or as a prescriber, but this new medication came out in recent months, and Dr. Myers says that there's a whole pipeline of medications that are going to be approved in the next few years that again are going to greatly increase our ability to treat this disease in all of its stages. So as I said, I think what's coming is going to be just mind-boggling. Of course, I keep telling my son he's going to live to 150, if not forever, because what's coming with genetics and nanotechnology and individualized, therapies and all. I mean, I'm jealous. He's 27, so he certainly could live well until beyond 100, I think. So we did that. If you're interested in my work with the medications, etc., this is my main website called Medication Sense, like commonsense.com. And then the second website is my psychiatry, psychopharmacology website. I specialize in anxiety disorders mainly, which are very, very treatable when treated properly, which isn't always the case. And I think that's it.
Dr. Cohen,
Yes.
could you give us a comparison between the MRI guided biopsy and the color Doppler? I mean, what does one have that the other doesn't have? How do they complement each other? Is one superior to the other?
Well, my feeling is that the MRI is going to be the game changer, because the color Doppler has been around for a while and has been accepted, but it's only done by maybe 2 or 3 dozen doctors in the U.S. that I'm aware of. And it hasn't really been accepted. It hasn't been rejected. It just hasn't been adopted by the broader medical community, although you would think it would have an important role, but it just hasn't gotten there. The MRI, I think doctors know what that is. They trust it. They've been using it for all these other issues and diagnoses for decades. And I think that's going to be the big game changer. I trust it more. I trust the MRI more too than color Doppler. I use color Doppler as a confirmation study, but if it weren't available, it would have been okay.
Some of us that have MRIs, color Doppler, and they brought them here, and we see them, and you see the red, the vascularity. What does the MRI show for the tumor?
My understanding is it actually operates on a very similar factor, which is vascularity.
I have a question for you, just to conclude on your situation. What kind of regimen or activity are you doing right now in your active surveillance mode?
Well, I do PSA every 3 months. I see Dr. Scholes every 6 months. We do color Doppler. We do digital rectal exam. It's fascinating with the color Doppler, and because you're laying there on the table, and he puts the screen where you can both see. He can see it and I can see it, so I can see what he's seeing, and he can point it out to me. And if one were to need a guided biopsy, it would be actually a lot easier to do it in a doctor's office with the color Doppler right there, and he would be showing you what he was aiming for. MRI, I think, would be more cumbersome. I'm not quite sure how they do it because I haven't seen it. But and then we do the MRI every year, and I had an MRI at UCLA with a bigger 3.0 Tesla machine, greater magnification, and that showed the very same thing that the first MRI showed.
What about diet? You give me your egg roll at lunch. What is your diet?
I don't eat that greasy stuff. I'm pretty much of a purist. You know, I am a vegetarian, but even within that, there are things to learn. And I exercise. I've always exercised.
Okay, let's have some questions. Let's start here, and we'll go over there. Any questions over here? Okay. How about? All right. Question.
Well, a little bit farther down the road, say you've already had a prostatectomy and your PSA is doubling. I mean, doubles and doubles. And my doctor says at 4, he's going to start the ADT. Do you have any knowledge of about that?
I really don't, but what I would say, if you're not comfortable with it, get another opinion. I'm big on getting second and third and fourth opinions. I probably talked to 12 doctors or 15 doctors as I went through all this, because at first it was surgery, and I spoke to 4 doctors about that, and then I considered radiation. I actually tried it, but I had a reaction to it that I had to stop. I think that which was good actually. And I talked to Dr. Scholes. I called some of the HIFU doctors who will talk to individuals. You can call them because they're looking for people to add to their studies that are being done here. HIFU, the high frequency ultrasound, is available at Cleveland Clinic in Canada. It's available everywhere else in the world except here where it's in studies. And you can call these doctors and they'll talk to you because they're seeking subjects for their studies, and they'll tell you a lot about it. But I always believe in getting second, third opinions if there's any doubt in your mind about the course. And I think with something like that, if you had any doubt about it, I wouldn't hesitate.
Well, have you heard what's typical for when you start the ADT? Typical.
I'm going to turn to my colleagues here who might know a little more than I do.
Yeah, let's remember as the questions start going here that his specialty is not prostate cancer, so he can't get into a lot of the details.
Yeah, I had failed or recurrent cancer and had ADT, and it wasn't appropriate for me. It was the injection, Lupron. Don't recommend it. It has bad side effects for some of us. I got atrial fibrillation, and then I had a stroke. So be very careful on what you take, and see, get second and third. How many? You got 15 opinions, and,
right.
And so forth. And he's a very knowledgeable person. So before you go into something, make sure. We got some questions here.
You're still insured by Kaiser?
No, actually, I left Kaiser, and the reason I left Kaiser was after I went to this insidious group of fellows meeting for lunch and learned about the MRI, I went back to my doctor at Kaiser, very experienced man. We had a good rapport. He treated me well. And I said, why don't we do an MRI? And he said, no, I don't think they're ready. I said, well, what's the harm? So I said, well, look, would you please give me a prescription referral for MRI, and I'll pay for it. I don't care. It's $500, $550. And he said no. So I had a doctor friend write me a referral because I needed a referral. They didn't want me to write my own referral at Sharp. But when I realized I was beginning to go in a different direction, again, time was fortuitous because there was a window to get out of Kaiser and sign on to a private policy.
Is that the Kaiser in San Diego?
Kaiser in San Diego.
So you left Kaiser?
So I left Kaiser.
A new insurance coverage?
Yes.
With the pre-existing now of...
Well, I don't think there was, I was Medicare. So pre-existing doesn't matter anymore. God bless Medicare.
Okay, question here.
My question is about the comparison between the two different C11 scans, the choline versus the acetate. I think one is FDA approved, one is still in clinical trials. Is one considered more accurate than the other, or is one more likely to result in a treatment change because it's more accepted?
I'm not aware that there's any great difference between them. Does anybody else?
I had the acetate and the Dr. Almeida. I asked him that question because last year up at the conference, we had a proponent of the other thing. And I asked both of them. And Almeida, you know, you were familiar with the medical profession. He's not going to criticize the other. He says, I examined them in great detail and I chose this, the acetate, as being the best and most appropriate. So that's all I think you'll get from people, and I would agree with that because it did clarify for me that I have it in my seminal vesicles, but it has not spread. I now have a baseline that I can then, later on, if I have some concern, go back and I got a baseline that says, well, here it is, and now here's where it is, and no change or whatever, so that's very good. A question right here.
Dr. J, do you have any experience and comments about circulating tumor cells?
No, I don't. Actually, it's on my list of questions to ask Dr. Scholes when I see him.
Okay, here.
How do you talk to doctors? Okay, I'm Kaiser, and I suspect that I'm not really getting the best advice possible, although I'm doing okay. Now, it sounds to me that you talk to 10 or 15 doctors. How in the world do I find the doctors I should talk to?
Okay.
And how do I get to them? Because I get somebody to say, we are interested, and you get somebody to talk, you get to secretaries. How do I get to talk?
Well, I think it's hard to talk to doctors directly because they are, as I am, reluctant to give opinions someone I haven't even evaluated. So I think if you want to get an opinion from someone, you have to make an appointment and see them. Now, I'm not aware of anyone here in San Diego that really is current with the things I'm talking about today, but there's the group, the medical oncology specialists, Dr. Scholes, Dr. Lamb, Dr. Turner, I believe, up in Marina Del Rey. There's a Dr. Chin, Douglas Chin up in Los Angeles. There's a Dr. I think it's Osaka Yukimura at USC, who I did see when my PSA jumped up again, as it did this past October, and I was pretty upset about it, and Dr. Scholes didn't seem to be. I wanted to be sure he was right, so I saw Dr. Yukimura at USC, and he was terrific, and he said, you know, prostate cancer doesn't jump your PSA that way and then drop down again. It doesn't do that. So I felt reassured getting that second opinion. In the book, I mention a lot of these doctors. I probably mentioned 10 or 20. I don't know exactly how many, but I didn't want to be cheerleading for them, but I did mention them in relation to who does HIFU, who does cryosurgery, and then some of the references are from Dr. Scholl's book or Dr. Scardino's book at Sloan Kettering. So you have to do some research, but there's a lot of information online. There's information in the book, and you can find them. Now, within Kaiser, I'm sure you can ask for a second opinion there. Whether you'll get anything different than the usual company line, I don't know.
The biggest issue, I think, is that consultation is probably going to cost you. It's not going to be payable by Kaiser.
Okay, so I get out of Kaiser and I pay for myself.
Now, are you Medicare or are you?
Yeah.
Well, many
you probably are.
yeah, many of them take Medicare and supplemental. My doctor, Dr. Scholes does. His group does.
Okay, over here.
You said that your Kaiser doctor said no MRI, and then you decided to get an MRI
Yes.
yourself
Yes.
in San Diego.
Yes. The first one I got was at Sharp Hospital.
Right. And then because of that, they determined that because of the MRI result, you wanted to have a biopsy.
Well, I already had the biopsy.
Oh, you had the biopsy?
Yeah, I did the usual high PSA biopsy, positive surgery or radiation.
Then why the MRI after?
Well, I wanted to see, they only found it on one side, and I wanted to see what we're really dealing with. Was it truly all over the place? Was it in a safe area, a reasonable small size, or was it much larger than we thought? Is it a dangerous area on the capsule or looking like it was spreading?
I'm going to have an appointment with Dr. Lam next month.
Right.
That will be color Doppler, maybe, but no MRI. But you said
Well, he
MRI
might do the MRI after he does a color Doppler.
Oh, he has the facility also?
Well, he'll send you to UCLA.
Or to another, okay, for MRI, I see.
Okay, we have a question over here.
I have two questions. One, I'm scheduled, I was recently diagnosed, I'm scheduled for a bone scan and a CAT scan. Will that actually tell me whether or not it's out of the capsule? Or should I have the MRI done to see if anything is spread? I'm at,
Well, that's a good question, because I had those studies done. My doctor at Kaiser said, we usually don't do them for your stage, which was intermediate.
mine is
He-
intermediate, it's at 10.13.
Right, and they've done a biopsy?
Yes.
And what did the biopsy find?
The biopsy found that I had 4 out of 12 on the pores.
Right.
But I have them bilaterally.
Bilaterally, okay.
I have, my highest percentage is 40%. The rest of them are very low, down in the 10%.
What is your Gleason?
My Gleason is 3.3.
See, now you're the kind of person who might not really need anything extreme. I don't want to lead you in ways that may not be correct, but Gleason 6, like I say, Lamb is saying and Scholes is saying, is kind of on the edge of being cancer. And the fact that your 4 positive biopsy cores, only one of them was, 40%, but the rest were 10%, which is low. You would definitely benefit from color Doppler or certainly MRI to know what are you dealing with. Because the ones that are 10% might be small, insignificant cancers.
Okay, so with the MRI, is that a treatment or is it just a diagnosis?
It's a diagnosis. You have a better idea of what you have and where you have it.
Okay, so could I get that before I do the CAT scan and the?
You could. You could. And what we were mentioning earlier about Dr. Almeida in Arizona and the Mayo Clinic up in Minnesota, this new carbon-11 acetate or choline PET CT scan is a better test for metastases than the ones you mentioned.
Then the CAT scan or the?
Yes.
Or the bone scan?
Yes.
One other question, my wife has a question, but you said you're a clinical psychologist too, right?
Psychiatrist.
Psychiatrist. Well, I have very bad anxiety.
I'm the man.
We have a speaker coming up in August about that.
In the auditorium, but I know for a fact when you do get newly diagnosed, your mind it's something that just triggers all of this anxiety.
Cancer is a tough word to get out of your head.
Yeah.
And the statistics are that there's a sharp increase in heart attacks. In the 3 months after diagnosis, there's a sharp increase in suicides. And I think if as these new treatments become part of our everyday approach, a lot of that will become less because men will have a better, clearer path and better, less emotionally trying treatments to suggest.
So are there any suggestions you have, maybe just briefly, that would help some of us get through the night, other than
I would,
ZQL?
the first thing I would say is make sure you sleep. Even if you have to take medicine, make sure you sleep. That's number one. Diet, exercise, of course, and that's where I would start everybody. Now will that alone be sufficient? I don't know, maybe not. But inform yourself, do the tests you can do, get second, third opinion if you need to. And if you need to talk to somebody, and as Gene was saying, there's actually a psychologist coming to speak in a couple months. You come back, you talk to her.
Let me just share with you my experience on getting a bone scan and a CT scan. I had a color Doppler. They located it. I got a Gleason of 8. I had a targeted biopsy, right? Just 5 needles, that's all it took in validate. Also, in case, this is Dr. Bond, he did a biopsy of my seminal vesicles because he thought that was in there, and that came out a Gleason of 8 and seminal vesicles, which most urologists don't do at all. A bone scan, when I talked to Dr. Almeida, which was really a super bone scan, what that process is, he said, boy, I haven't seen one of these in a long time. I had the old-fashioned one. And they tend not to detect things until there's something that's pretty evident, and you'll know otherwise too. It's just more of a validation. So they tend to get a negative response on both CT scans and so forth for it to show early on. So if you have some concerns, you want to have either a color Doppler or an MRI, because in general the bone scan that they have now is old technology, and hopefully they have it improved. Next question, over here.
Is there any evidence of your cancer with that digital rectal exam?
No, that was normal.
Okay, let's get over here.
They missing out the middle.
Go ahead.
I'm a little confused. Did you in fact have surgery and have your prostate removed or not?
No, I dodged that bullet. I'm sorry.
Oh, so you did not have it removed?
No.
Can I just make one comment to the gentleman on my right? I've had my prostate removed 8 weeks ago. Before that, I had an MRI. MRI showed 2 suspicious lumps, one behind my heart, which they could not take a biopsy of, and one in my bladder. And they didn't know what it was. So I went and I had the C11 acetate. And that showed up that in fact it had not metastasized. The suspicious lump, which of course I thought was cancer because I had the same issue you had, was in fact not cancer. It was just a growth, a number of little growths. So the C11 acetate scan, even though I had to pay for it, gave me far better results than a straight MRI, because it's an MRI as well.
Well, the MRI is helpful for the prostate itself.
I had it on my entire body.
The C11 was for any sign of metastases. Yes. Yeah.
Okay, question over here. All right, here.
I gather you've taken all treatments up to this point. Is there
That's right.
anything you are thinking, you're inclined to, if you had to?
Well, Dr. Scholl said to me, he said, 70% likelihood this will never be a problem for you, because it's Gleason 6. But he said 30% chance is you may need treatment. And I probably would lean to one of the focal therapies as long as it's just a focal lesion, because of the much lower risk of affecting, nerve functioning and sexuality, bladder control, etc. So I'm leaning toward, I'm watching very closely the studies on laser, but I'm also looking at cryo and HIFU perhaps.
Okay, here.
I didn't exactly get one of your answers. Did you say that you could not detect your cancer with a digital test?
The digital was normal. It's always been normal. And of course, if it detects on digital, it means that the lump is somewhere close to the periphery.
We're all told to exercise regularly. I wondered if there's any significant study done for or against.
I'm not aware of any studies about exercise. Diet, there is some study. And pretty much everybody recommends a Mediterranean kind of diet, that kind of thing. I'm a believer that exercise enhances blood flow everywhere. It helps tissues get nutrients and cleanse themselves, and it's just basic. So I've always been an exerciser, and I don't exercise hard. I'm allowed to not do that anymore. I walk 2.5 miles briskly in the morning, and I swim every morning, and my dog demands it anyway, so what can I do? And I swim twice a week for 30 minutes, and that way I get upper and lower body. But when I walk for about 50 minutes, and about 30 minutes I can feel my body warming up. You can feel the blood flow, and you can feel the heat, and it's a really great feeling. So I do recommend it to everybody, really.
Okay, question there.
The study you had
I think it was regarding surgery, and maybe approximately 30% of the men actually perhaps needed it.
Needed it.
What could have been done for the other 70% that had it that didn't really need it, based on what you've looked at so far?
Yeah, well, you know, it all depends on what they're told. You know, a writer wrote an article about the book on one of the websites, the news websites, and there was a reply, and somehow some people read it as advocating active surveillance, which it didn't. I don't advocate anything specific. I advocate getting good diagnostic information and then getting as many opinions as you need to really make an informed decision about what you feel you need to do. But this man is getting radiation. He said he had one positive biopsy core, which isn't very much. That's usually low risk, but he didn't tell us his PSA, he didn't tell us his Gleason. But what was the question? Oh yes, it depends on what they're told. You know, is anybody here from the article in the Del Mar newspaper recently? There was an article on me in the book, etc. And the writer called a radiotherapist at Scripps, where they're putting in a big proton machine now. And he told him, he said, no, these can always come back and they can change and you can miss them. You really have to get it out, you know, right away, and gave him the message that most doctors give most patients. So the real key will be did all these men actually have MRIs prior to making their decisions, and informing them that actually, especially with the lower grade cancers, often they really don't need bilateral. They don't need prostatectomy. We don't know if those men were told that. They may have been, like me, told, yes, this is what you have to have. You have such a level of PSAs, so many positive cores, and this is what you must have. And we're learning now, as we can study these things so much more intensively, that isn't necessarily the truth. For the 50,000 men who have prostatectomy, 40,000 don't need it, and similar numbers with radiation therapy.
Okay. Oh, no, sir, excuse me, you already had a question. Anybody else here? Okay, now you.
Prostate infection increases the PSA.
Yes.
Okay, what about hemorrhoids?
No, I don't think hemorrhoids should. Hemorrhoids come from different tissue. It's rectal tissue. It doesn't produce PSA.
And also, yeah, thank you. And what about PCA3?
PCA3 is something I really can't tell you much about. I don't know much about it, but it's a good question, and there's information online, or you can ask your doctor about it. You know, I've read about all these. I'm not sure, and they sound great when you read about them. Well, why aren't we doing this and why aren't we doing that? But I'm thinking clinically maybe they haven't lived up to their purported reputation. And I'm a staunch believer, as I said before, in continuing the PSA. I think the idea of stopping doing it is crazy. Early detection is the name of the game with this disease.
Question there.
What is your take on biopsies? And the reason I ask this is I have very low grade. I had one core out of 12. It was 10%. I had a biopsy done. It was 3+3. And then I've had the color Doppler. I've had the MRI that showed nothing more serious. But yet both my oncologist and my urologists want me to keep doing biopsies every year. And I am really against doing it.
Well, let me tell you a story. I have this client. He's an attorney. He's done great in my psychiatry practice, and we started talking about this. And he said, and he's about 55. He said his father was diagnosed like 4 years ago. Father's 80, something like that. And they keep wanting to do biopsies. You know, every year they've done a biopsy, and his father hates them. And I said, well, you know, there's this doctor in Florida, and there are others too, some of the people we've already talked about, but there's a doctor in Florida, in Sarasota, named Ron Wheeler. And he hates biopsies. He hates doing biopsies. He's probably the leading person saying that biopsies spread cancer and all. Most doctors don't believe that, but he believes it. And he says, we'll do anything. We'll do MRIs, we'll do color, we'll do whatever we have to do to try to prove you don't need a biopsy. So I would think, as Dean just said, that if you continue the MRI, color Doppler, if your doctor does it, and your PSA stays level, I'm not sure you would need to do it consistently.
They keep saying that's the gold standard.
Well, you see, here's the gold standard nonsense. I love this stuff. I was involved in a legal case. I do expert opinion stuff occasionally because of my background in medications and side effects. And some defense lawyer of a doctor who over-medicated a patient who died. And he said, well, the gold standard are these studies by the drug industry. And I said, well, that's what the drug industry says. It's not my gold standard. It's nonsense. You know, so yes, mainstream medicine loves the gold standard concept, but that doesn't mean it's always right. And by the way, the gold standard right now is high PSA, positive biopsy, go right to surgery or radiation. And that's going to stay that way for a while, even though what I'm saying today may say, at least for the majority of men diagnosed, that doesn't work. That's not necessary. So they'll use that. That's what doctors, you know, and I'm not putting them down. This is what they know. This is how they're trained. They won't make changes until they feel it's been sanctioned and certified. And for them right now, that is the gold standard. You should get another opinion with someone who is on the cutting edge, so to speak, and get a different point of view. You know, the doctors up in LA, they can, you know, Marina Del Rey or LA, the ones I've mentioned, all have the technology to do MRI or color Doppler or both. And my guess is they won't do biopsies unless they feel they really have to. I am not scheduled for a biopsy. It's been a year and a half. Everything else is fine. I don't think they're in any rush to biopsy.
In that case, and I'll wrap up, how often do you think you should do a color Doppler or an MRI?
We're doing the color Doppler every 6 months. We're doing the MRI once a year. Or if there's some change that worries us, then we'll do it quickly.
Let me comment on the frustration that Jay and I share with, why aren't these doctors prescribing these new techniques and so forth? So I've done some research on it, and what they have, the American Urological Association, AUA, which is the guiding organization for urologists, have what they call the best practices. And this is litigation proof. If they follow the best practices, you can't sue them for malpractice. So the best practices, you ought to read that. It was written in 2009. And it does mention color Doppler, but it sort of says it's not necessary. and things like these, you'll run into that. Well, yeah, we could do that, but it's not necessary. So they're following a litigation shelter operation and not taking risk, maybe subjecting you to some risk, but they're not taking the risk. They're following the procedures, and it takes time for those things to get updated. So it's not because they're ignorant, they're litigation concern.
Well, it's litigation, but it's also just becoming comfortable. Doctors don't want to rush into a new technology or new treatment and then find out it didn't work well or did harm or it led to misdiagnosis or undertreatment. I mean, doctors, the whole thing about it, it's probably all over, let's whack it out, is because they're so afraid of missing one. And then a man develops advanced prostate cancer and dies a slow, painful death. So there's also just the concern that it's better to overtreat than undertreat. And they really haven't had the technology to separate in a better way that now is happening.
Question.
Quick question. Any thoughts on why no one in San Diego is embracing these more alternative options that Marina Del Rey, Palm Desert, Ventura, but here, seventh biggest city in America, we don't have apparently a urology group that wants to embrace.
Well, you fellas have had discussions with some of them here. What do you think?
We have. It's just sad to say because of the population. First of all, Marina Del Rey isn't very far away if you really care about your health. That's my first statement. And I think even Dr. J and I had that conversation to begin with. But the answer is they haven't yet embraced the technology. And I'm sorry to say that, but that's the truth.
There's another element that's somewhat unique to San Diego. You know, why is our gasoline prices higher than elsewhere? It's the market. This is not an easy market for a doctor to come into. It's very HMO dominated. So if you're a physician you enter into an HMO culture here. And we're up in LA, it's a little more open, ease of entry, and it's more of a high tech, at least for prostate cancer. We wish we could just give you a roster of people that we personally recommend and have good experience with. We have not been able to do that as yet. Hopefully we could. Okay, question over there. Yes, John.
Yeah, for your annual MRI, are you gonna do it at Sharp?
No, I'm going to do it at UCLA because it's got a bigger, stronger machine. The Sharp one was very helpful initially for me, absolutely essential. But I'm going to go with the better, stronger machine. And it's one thing that I always want to clarify, which is, and I've done some radio shows and all about the book, which is these are big, expensive machines. Most hospitals don't have them. Either they don't believe, haven't been convinced about the technology, or it's too costly. People in smaller towns or less, urbanized areas, they're going to have to travel. But fortunately, like I said, they are available in different places across the country for people.
I have a question. On the MRI, all you need is a prescription from a doctor, and then a referral, and then you can go to, like, if we get a referral from Kaiser, but you're saying Kaiser...
They won't give you the referral is the problem.
Well, can't you do file a grievance or something and get a referral?
I don't know. I didn't go that route.
John responded to that. He went through the whole 9 yards.
Yes, go to membership services immediately. Membership services, Kaiser.
Right, but if we get a referral, we can go to UCLA, and UCLA will go off the referral, no problem?
I believe so.
How much is an MRI at UCLA?
I don't know what UCLA charges. I know what Sharp charges.
What does Sharp charge?
It was $550 a year and a half ago.
Still the same price.
Still the same price?
Those are cheaper than mine.
And is that out of pocket or covered?
Out of pocket.
Now, if you do the watch and wait, and this is my husband's, how slow is it? Like, can we wait a year and just take our time and just do the watch and wait?
I would get all the information you can.
Yeah. You've got to get the initial information to make your determination. That will tell you how quickly you need to react. But my first response to you is don't panic, because you're not going to die soon. You saw the hands around here, didn't you? Okay.
Well, and like I say, like everybody, it's a slow, especially a 6, is a very slow growing cancer. You have time to sort this all out. I would recommend. Well, that's why you get the MRI, so you know what you're dealing with. I would get that as soon as you can. Yeah.
We have a question over here.
It's not a question, it's an answer. There's a 3 Tesla machine 2 stops up the freeway from here at the VA.
Where?
The VA has a, well, it's not just the machine, it's the
Software.
It's the software, and it's a contrast study, gadolinium. So whether they do that particular MRI for prostates, I don't know.
They do not.
They do not?
Not yet.
Are we talking about MRI or color Doppler ultrasound?
MRI right now.
You have a question?
Well, my question was which, just wondered what technology you said wasn't here in San Diego yet, was it color Doppler?
I'm sorry.
I'm questioning what technology we were talking about that you said wasn't in San Diego yet, whether it was color Doppler ultrasound or MRI.
Gene, if you want to comment on the color Doppler?
The MRI that Dr. Jay's talking about is called a DCE MRI that's done at Sharps Children's and MRI Center. And that is, as he has said, that's on a 1.5 Tesla. That gives you a very good basic image, as what he found out, of what your condition, where the cancer is located, how large it might be. That's a very good indicator of that. That's the only place in San Diego that I know that does it. No one in San Diego, with one exception, and I'll talk about briefly, that does color Doppler ultrasound. And we have found out that color Doppler ultrasound is available at Kaiser if you ask for it, but the doctor, I can't say her name, Worstel, will do color Doppler ultrasound, but she's not a big advocate of it. You need to understand that going in. But I had one gentleman that gave me a report that he asked for it, got it, and was able to make his decision based on it. So they will do it. They just had a seminar on it, but I didn't attend.
Well, how do you spell her name?
Yeah.
W-E-R-S-T-L-E.
Thank you.
Is she a urologist?
Yeah.
She's a urologist. She's at the Otay Mesa facility.
Question over there.
I'm a little confused. I went in, started out with a back pain, so they gave me the back guy, and he gave me an X-ray, and then he gave me an MRI, and he gave me a CAT scan. All he could say from those was that I had a little arthritis in my back. So then they gave me a, what's the next one? For the bone scan. They gave me a bone scan, and they found 4 spots that were questionable, and then he gave me a PSA and it came out 26. And then I had a biopsy with my Gleason 7. So why didn't the MRI, was that a different kind of MRI that I had?
Yeah, it's a very specialized MRI.
Oh, so it's the
For
MRI
prostate.
Oh, okay. The
Different MRI that you got.
So that MRI I had was worthless for prostate?
Well, if they were looking for, yeah, well, they weren't looking at your prostate, they were looking at your back.
Well, no, what else? So you have to have different software to find out different things?
Yes.
Thank you.
And you have to aim your MRI in different places, too.
You're looking for how fast?
Let me just make one more comment, because I talked about Cipro and Levaquin, the antibiotics. These antibiotics really are about as good as it gets for prostate infections. However, there is another one that is effective too. It's called Septra, S-E-P-T-R-A. Now, if you're curious about this, and the Cipro and the Levaquin are usually what doctors prescribe for prostate infections or suspected prostate infections. I like Cipro better because, again, as part of my approach to medications, Levaquin is one size, once-a-day drugs. So there's this been big rush to once-a-day drugs because people can remember them better. The only problem is you have to load up a lot of medicine to last the whole day. It's like saying, well, which is better? If you need to take 4 cups of coffee a day, is it better to take all 4 at one time? Or is it better to take 1 every 6 hours? So Cipro is a 3 or 4 times a day drug. So I don't think the body gets hit with as powerful a dose as with Levaquin, but that's just a personal opinion. But I would always recommend people take Septra first. Now, Septra is effective about 70% of the time. Sometimes it isn't. But most doctors will just prescribe the Cipro or the Levaquin because that's what they've gotten accustomed to. But if you can avoid that, I would recommend it. And if you have any doubts about what I'm saying about Cipro or Levaquin, just go online and write Cipro side effects. There are a number of websites, good websites, of young, healthy, vigorous people who took these drugs for sinus or bladder or prostate, and it absolutely changed their lives for the worse. It's a bad drug when it acts badly. So it's a drug that if you need it, you take it, but if you don't need it, you try to take something else.
Very scary.
Very scary.
The Cipro, you saw it. That was I took it, before my first biopsy because it's strong, right? Like you said, I didn't know. It says, you'll destroy your tendon,
That's
your
right.
tendon, then you cannot walk.
That's right. The article I wrote on Cipro and Levaquin and those drugs was about severe nerve injuries from these drugs, which they can cause. And it happened to come out, if you remember, after 9/11, about 3 or 4 weeks later, we had the anthrax scare. And the CDC, Centers for Disease Control, recommended Cipro as the treatment of choice. And I already had the study done, and the journal was going to put it out a month or 2 later. They rushed it up. It came out in the news, and as soon as the description of all the severe side effects that could occur, CDC changed course, and they dropped Cipro, and they recommended penicillin and doxycycline. So these drugs can be really effective and life-saving drugs, and they should be saved for that kind of situation or for a situation where nothing else works. If you need it for a severe prostate infection and nothing else has been helping, then certainly take them. I would take them. But if there are other choices, I'd go with the other choice first. Yes?
What was the medication that you recommended?
Septra. Septra. S-E-P-T-R-A. S-E-P-T-R-A. And every doctor knows what that is. And they'll say Cipro is better, and you say, fine, let's do the Sepra, and if it doesn't work, then we'll do the Cipro.
Any questions here? Go ahead.
Would you recommend the CyberKnife for treatment?
CyberKnife is a high-intensity radiation therapy that is so intense it destroys the cancer in 5 days, 5 days of treatment, one in a row, as opposed to a cooler beam with the usual IMRT, which is done 5 days a week for 8 weeks. So I'm not aware, I looked at the studies of CyberKnife initially because it intrigued me. I think the results are probably equivalent in terms of cure, but I don't know that it offers any advantage except it's more convenient. But I also have heard that the side effects from it are also worse. They might be more temporary, but they can be worse because of the intensity of the beam.
Just one question more regarding you on your slides. Focused laser ablation.
Yes.
Could you say a little bit about that?
Yes. Focused laser ablation is a new technology that's in clinical trials that people can actually sign up for now. And using MRI, it positions the probe right into the cancer nodule, and it uses laser-generated heat to actually kill the cancer cells and a small area around it.
Where is that being done right now, do you know?
I know it's being done in New York City by
The only one I know
a
of.
doctor named Dan Sperling, S-P-E-R-L-I-N-G. If you go online and just write laser therapy, he's paying a lot of advertising because he comes up 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. But he seems knowledgeable, and he is using it with MRI technology, which is really an excellent way to do it.
Question?
I was just going to say on that note, the laser ablation versus cryo, can you compare the two and say what's more interesting about laser versus cryo, or the other way around?
Well, to me, what's more interesting as a possible patient at some point is that with cryo, they use freezing, and they create a small ice ball to freeze the cancer. But the problem with cryo in the past, and I'm not quite sure where it is right now, I'm actually in the process of sending a letter to Dr. Yukimura up at USC about this, because he's done studies with this with Dr. Bond up in Ventura. And in creating the ice ball, there has been injury to nearby structures. For example, when they've done half prostate removals with cryosurgery, there is usually injury to sexual functioning. Now, whether they'll do it in a very limited focal method, I don't know if they're applying it to that. I think they will be, but I don't know where the status of that is at this moment.
So you think the laser has a promise of less injury too?
Yes, that's my sense of reading what's out there and reading the studies. I may be wrong, but that's what I think. Yeah.
Question over there?
Damage to the urethra, side effect of cryo?
Well, it depends what they're doing. If they do the whole prostate, there will be some. But if they do half or even just a focal, a lumpectomy kind of thing, there should be less.
Less.
Yes, or no injury.
That's what I'm looking at, no.
Yeah, but again, you can contact these people and ask them, or write to them and ask them.
I have 2 guys that have done cryo now once, and I can get you in touch with those people if you'd like to talk to them. The one that I know the guy for many years, did 10 years of active surveillance before doing cryo, focal cryo, and he has had no after effects.
And he had that done locally?
With Dr. Ukimura that he mentioned.
Oh, okay.
That nobody down here does it that I know of.
Question over here.
In 2003, I had cryo with Dr. Bond. half of the prostate, and I've had no problem with it. So
Great.
it worked okay until my PSA eventually started to rise again, but for the better part of 10 years, it was okay.
Why don't you two talk a little bit on the other thing?
Dr. Bond, you said?
Yeah, this is Duke Bond, he's up in Ventura.
You
And
and Luke and Murrah consult with each other quite a bit.
By the way,
Any,
Icamura will do HIFU in Mexico if you ask him to.
Oh, does he? I didn't know that.
Yeah.
And Dr. Chin will do it too, Douglas
Yeah.
Chin up in LA, he does HIFU also.
But you can't do it in the States.
No, it's not, it hasn't been approved in the States yet, it's in study. This is HIFU, a high-intensity focused ultrasound. But you can see American doctors, and they usually have arrangements for surgical suites in Bermuda or in the Caribbean or in Mexico, etc., that men can go to and have the HIFU operation. Yes, John?
Yeah, with those focal treatments like cryo and HIFU, you can do the one side 1 year, and 10 years later do the other side when it spreads to the other side.
If it's needed.
Which is the same as doing a prostatectomy or whatever.
But 10 years of less problems post-treatment.
Question?
Comment about supplements?
Well, it's an interesting area, and I'm not sure anyone's really pinned anything down in particular. I have played around with supplements because I've always been interested in the alternative side of things as well. There are a lot of studies on green tea extract and others in animals that show benefit, but there have been a few studies in humans and it doesn't show benefit. So I'm not sure there's any really hard data. There were a couple reports recently by Dr. Moyad in one of the newsletters, and I think Dr. Myers too has written a book on supplements and diet.
Yeah, one of the issues unpacked, he updates that. He's for them, but he's concerned about overdosing. Take a minimal amount. I just like to comment about biopsies because this has been a concern to me, and you've heard about infections. Some of you may not have been here last month. Dr. Lamb talked about biopsies, and he is a strong advocate of targeted biopsies. Prostate cancer is the only cancer where they do random biopsies. He pointed out, for example, if a woman has breast cancer, they're not just going to jam 12 needles into each breast. They target that. And it's just appalling to him that urology just does these random things. The situation is then compounded when most urologists don't trust what I call the shades of gray. If you get a bone scan or a CT scan or even an MRI, you're looking at shades of gray. It's not cancer specific, whereas a biopsy is. You give it to a pathologist, he takes a slide, he looks at it, and he certifies it is a cancerous cell. So when you've got a situation, I went to your oncologist recently, and they're driven to want to do an MRI, because that's the way they can be sure that it is cancer or not. So this is another thing that drives to do that. Unfortunately for us guys, it's a random shot. And so if you're going to have one, do it targeted. Question back there.
Are you hoping that a safe, effective systemic treatment may come along before you need treatment? And if so, what are you keeping your eye on?
Well, I'm hoping for anything and everything. I don't really know that much about systemic treatments. Are you thinking of something in particular?
Immunotherapies,
Sure.
oncolytic viral therapies,
Yes.
etc.
Genetic specific and
Yes.
all kinds of things. Nano, I mean, that would be great. I'm a little suspicious of that kind because it goes everywhere in your body, not just to your prostate, unless they find a way to really genetically code it in a way that would only go to that one place. I think that's a ways down the road. But sure, if at some point I do need treatment, if there's sign of spreading or PSA starts really peaking and staying high, I will need treatment, and I hope to have as broad an array of choices. Every year is in my favor. as far as that's concerned.
Have you heard about Larry Pope, Nutritional 2000? You know, they've been working for through supplements. He's out of Hong Kong now. Used to be out of the U.S., but he had to move his pretty much his practice to Hong Kong.
And what does he do?
He's treating prostate cancer through these nutritional supplements, through pills and creams and stuff like that.
Yeah, you know, I'll tell you, it kind of reminds me of Steve Jobs and his pancreatic cancer. You know, although I have a really open mind when it comes to alternative stuff, and I've written books on natural therapies for migraines and high cholesterol, I'm really leery of that until I see something really solid. You know, I think it's really easy. You know, I've been living and eating a diet that's probably consistent with a lot of that. I'm not taking, you know, maybe certain specialized supplements or not. You know, until I'm really shown that this is really high certainty of cure, I'd rather go with what is available now. You know, if I need treatment, you know, I'd rather take it out in the safest, best way possible, but I'm really careful about that kind of thing.
Yeah, on the subject of supplements, I've done a lot of research on that, and there's, like you've been saying, you know, they say a heart healthy diet, preventive training diet, that's probably that's the basis of it. But in terms of supplements, there's not a lot of definitive research. There's some almost sometimes even contradictory. And a lot of the research is in petri dishes. Something seems to kill cancer, something
Right.
whatever. But there's a few things that I think I found are fairly definitive. And one is you need enough vitamin D, like
Yes.
5,000 milligrams a day.
I agree with that.
And there's some bad things you could do that increase the growth of prostate cancer. And it all has to do with excessive things. Even excessive multivitamins. There's one study says don't take more than 7 a week. Excessive calcium is bad, and that means like over 1,000 to 1,500 milligrams.
Which they were recommending, by the way, for bone health up until a year ago. That they've been telling people to take 1,200 a day for years.
Excessive calcium, excessive zinc, excessive vitamin E. They even stopped one study because the vitamin E was having such a bad effect. Excessive sugar, especially sugar spikes. Now, there's a couple of things that are, I can't get the definitive word on, and that's oils, like omega-3 is supposed to be good, but other people say it's good for cancer. You know, so oily fish like salmon and mackerel, omega-3, and nuts, you know, that are oily, and soy. These are things that I'm like, I can't figure it out whether it's good or bad.
Well, I think soy is supposed to have a slight mild estrogenic effect, which of course would help restrain prostate cancer a little bit. As far as sugar, I'm glad you mentioned that because there is some writing on all this. Dr. Scholl's, in one of the latter chapters of his book, Invasion of the Prostate Snatchers, talks a lot about spiking insulin levels, sugar intakes, and this is known to drive cancer, and what that mechanism is. So yes, that seems to be reliable information. You also hear about that adequate selenium is important, excess iron should be avoided, and a few other things. But there's not a lot of solid ground on all of this yet.
All right, we have a question here.
Most soys in the United States are genetically modified, about 90% of them.
So if you go to a health food store like Whole Foods or Jimbo's, they say it's organic. Theirs is organic.
It's up to you if you believe it or not.
Well, it wouldn't surprise me, actually.
Therein lies the problem.
Any questions here? Okay, back there.
If you're mildly anemic, would iron supplements be a bad thing?
Well, so now, do you have prostate cancer?
Yes.
You do, okay. I think a standard daily recommendation would probably be okay, but I don't know about higher amounts. Tell me about your anemia.
Well, I've scored really low on,
Your hematocrit?
what is it?
Red blood? Blood cell count?
Red
Your
blood,
blood?
yeah, that's it.
Is this new, or has this been the way you've always been?
It's been, you know, ever since they've tested it for several years, and every time I went on
taken the iron as recommended, my PSA went up.
So that's a concern, right?
So
What is, can you tell me your red blood count numbers or your hematocrit numbers? Because does the anemia is it secondary to after having your surgery or anything like that?
oh no, I'm on active surveillance.
Okay.
I haven't had any.
Well, sometimes my ex always had a low hematocrit, which is a measure of red blood cells. But it wasn't like terribly low. It wasn't like I can't move or walk kind of low. A lot of people, probably about 20% of the population, 25%. I love these questions because it brings out my general medical physician, experience. And I have a lot of patients. I give them medical advice. You don't have to treat every anemia if it's not causing symptoms, if it's not terribly low. If it's mildly low, you don't always have to treat it. So I'd get a better clarification from your doctor, and if you don't get a good clarification, ask for referral to a hematologist, who are the specialists, and find out, do you really need to take iron, or should you be taking it in a more organic way, like the foods that contain iron rather than a supplement, and the problem with your PSA seeming to go up.
We have time for 2 questions.
I have one on beverages, alcohol. But I love wine, red wine, Cabernet, stuff like that.
In moderation, red wine is good.
Yeah. So that's the thing, because you're talking about sugar, and I know there is a sugar content in most wines.
I don't want to make you paranoid about everything you eat. A glass of wine, or even a couple glasses spread over a dinner, it's probably fine. And hopefully it's not every night, or every lunch.
You've written a number of papers about statins, and a recent clinical trial has shown that statins lower PSAs, and laboratory studies have shown that statins have decreased cancer cell growth. Could you comment on statins?
Well, statins I can comment on because I've written a book on statins and natural therapies, and I've watched them being launched and then pushed at higher and higher doses that cause more and more side effects. I've written some papers at that website. I've written some papers going back a few years. If you scroll down, you'll see them. But they're always looking, every drug company is always looking for other uses of their medications to expand their markets. So I don't know if that is true. I haven't read the studies or the data, but see if there's other studies supporting it that confirm the findings. But I wouldn't take a statin right now, from what I know, which isn't much, admittedly. I wouldn't just jump on a statin just to lower my PSA level.
I read the laboratory studies, and just after my surgery, I took statins, and I got my LDLs down to like 50, and I didn't have any PSA, but then I started getting a pain in my eye.
Well, that's the thing.
And then I just did.
What were you taking at what dosage?
I forget what it was, what the dosage was.
Yeah.
It was fairly low dosage.
To get down to 50, you're taking a pretty good amount of statin. It's really even lower than the drug companies are recommending, and they're recommending it, pushing it down so you'll use more drug. But they have side effects. Finally, the FDA a few years ago, after 20 years of people talking about it, admitted that statins can cause muscle breakdown and memory problems and impotence, believe it or not, and other things.
Red yeast rice fit in there?
Red yeast rice is a natural, milder form of a statin. A lot of people prefer it because it's natural, it's not a drug, it's not synthetic, and it's a fermented form of a certain kind of rice that actually makes a lot of little mini statin molecules, a little bit of lovastatin, which was the original statin Mevacor, and they find it's more tolerable to them, and they can still get their cholesterol levels to go lower. Now, it's not as strong as the hard medications, and it still can cause the muscle pain, the joint pain, the memory problems, but much less often. So if a person wants to start there instead of a drug, that's fine.
What was the name again?
I'm sorry?
What was that?
It's called red yeast rice.
All right, let's, I want to make a mention here, $10.
$8.70.
The Best Buy book.
$8.75.
No, we charge $10.
Oh, you charge it. Gotta make, hey, you gotta pay for admission.
We get a bucket and a
And we had
quarter
to-
and
we had to
save
pay
you
the
on
postage.
shipping. We save you on shipping, bucket of, $10. Hey, let's hear for it for Dr. J. Thank you.